go over this and breeze through it a little bit, and I'll give you some things that I typically do, and I think good ways to approach it. So your differential is obviously your list of possibilities for a given complaint. What do you think that this list here is regarding? What kind of chief complaint do you think that we're looking at? Sure. Oh, it even says chest pain. Okay, so how do we get from that to this? A patient presenting with chest pain and a diagnosis of just pleurisy and cough. So I use a two-tier differential diagnosis approach. Now, I think this is more tailored towards emergency medicine, but I think that it is applicable in other cases, depending, no matter where you are practicing. I think it's always good to break it into these parts. So tier 1 and tier 2, that doesn't necessarily mean that one is 1 and 2 is 2. Those are ubiquitous. It just means that there's two separate tiers. And one of them being the most common, most likely diagnosis, right? And then the other one being the most deadly or debilitating. Now sometimes there's overlap. Both of those may be in the same tier. Sometimes they may not. You know, there's a difference between having a cough and a pneumothorax. So cough would be most likely. How many people do you see with a cough? Hundreds of thousands. How many people do you see with a pneumothorax? Not very many, maybe a couple a year, depending on where you work, especially non-traumatic and things like that. So you break those up into your most common and most deadly / debilitating, because some things won't necessarily kill you, but they will cause you to suffer irreparable harm that won't be able to come back, like a stroke or cauda equina or something weird like that. Okay, so most common, have you guys heard when you hear hoof prints think horses, not zebras? Right, yeah. So that's just thinking that, a headache is a headache and not a brain tumor or, a subarachnoid hemorrhage or whatever. Nausea, vomiting, diarrhea is just gastro and not something weird, zebra diagnosis. Not to say that there aren't zebras out there, and sometimes you need to go looking for them, but I think that the times you need to start looking for them is when you have ruled out the most common causes, and then you start to broaden your differential looking for zebra. So don't start off looking for a zebra, start off looking for what's the most common cause, and then expand into zebras. And then obviously your most deadly. So those are the ones you're going to send home and they're going to die or suffer some kind of irreparable damage or harm. I have a few of these most deadly ones up there: chest pain, back pain, headache. It's funny because those three things, those three chief complaints and then their associated diagnoses there are some of the most common things that you're going to see in the emergency department as far as complaints goes. That's the same thing with acute care, urgent care, family practice, pediatrics, all sorts of stuff like that. Maybe not so much pediatrics with these, but your adult side. So you're going to see these not only in the emergency department, but also in other fields. So recognizing that there's some potential deadly diseases out there that present with those complaints, making sure you have those in your mind. Okay, so how do we narrow down your list of possibilities? Well, we use everything that's available to us. And so I need to try to make a cool slide. I made this slideshow probably like 5 or 6 years ago when I first did it. And I changed it up a little bit, but it's major format the same. But I need to get something like I can get each one of those words being like a piece of a puzzle that like comes in and fit together. Wouldn't that be cool? Yeah. I think it'd be cool, whatever you guys like. Sure. Sure. You just want to get out of here. So each one of these is a little piece of a puzzle, and that puzzle fits to form your diagnosis. And that's what it's a big problem that I see with students every year from both programs, and it's never going to change, and that's all right because that's what you're on rotations for, is to learn. But if I can start to kind of plant that seed in you, is it not any one of these things does not make the diagnosis. It's a piece of a puzzle and it needs to fit together to come out with what you're looking at. So history, physical exam, epidemiology, lab presentation, etc. needs to all come together to fit and make that diagnosis. Just because you have an elevated troponin does not mean they're having acute coronary syndrome, right? What would be some other causes for an elevated troponin in the absence of a clogged artery?
Cardiomyopathy.
Okay. Cardiomyopathy. What else? I mean, it's kind of low-hanging fruit. You used to put the word heart in there.
Cardio and muscle, heart and muscle and troponin.
Anything else? You guys can think of anything?
Muscle pain.
Muscle breakdown? Does muscle have troponin in it? No. Did I lecture you guys on cardiology?
STEMI. Unstable
It was a
angina.
long time ago, but unfortunately you actually have to know this stuff coming up. Anything else? Can sepsis cause your troponin to go up? It can. Myocardial demand ischemia, it's called a type 2 STEMI. So you don't have blocked coronary arteries, your heart's just working harder than it has, and it can't keep up, so you start to develop muscle tissue breakdown. It has nothing to do with having a blocked coronary artery, it has everything to do with the myocardial demand. So what filters out troponin? So your heart releases it, does it just stay there forever and then disappear? Kidney. So would you think that somebody who has chronic kidney disease and no GFR would have an abnormally high troponin, right? All sorts of stuff can cause that thing to be elevated. So that whole thing there is meant to elucidate and focus in on lab. And this sucks, whatever. Lab is one piece of the puzzle. Just because it was elevated, yeah, I got this. And does not make the diagnosis, right? Piece of a puzzle. So here's a differential diagnosis, Pneumonic. It's long and tedious, but it's good and helps you kind of break these things in there and help build your list of diagnoses. That's something that you guys, as you start out, are going to be lacking in a little bit because you just haven't been exposed to them. But as you go over time, you start to build up your repertoire. It's just like a cook in a kitchen. When you start, you learn how, you know how to make a few things, and then in 20 years, you know how to make a lot of things. It's the same thing with this. You start out with kind of a small area, but then as you go on, you start to have more of those things in your brain. This helps bring them all together. Vindicate, I'm not going to go through all of those. Obviously, you guys can tell how we're talking about here with vascular, infectious, neoplastic, things like that. And so you think about, so if those are a presenting complaint, you have chest pain. So then start to build out your differential. And I'm saying vascular, and obviously there's a ton of vascular complaints that we do chest pain. AMI, PE, infectious, pneumonia, pleural effusion, empyema, neoplastic, cancer, and as you know, degenerative, iatrogenic, intoxication. I mean, all sorts of stuff as you start to go down and build up your differential based on that. You know, I think some of the more common would be vascular, infectious, obviously endocrine metabolic. You know, autoimmunes, kind of more zebra-ish type thing. Obviously, traumatic's pretty straightforward. I don't think that you have to worry about missing a traumatic injury when somebody comes in with a gunshot wound to their chest. I think you would hope that they don't have some congenital problem that's causing their hole in their chest. Okay, exam findings. So I don't know. I should cut this slide out too. You know, this is, you guys should know this. You know, Rales, pneumonia, wheezing, asthma. Vital signs, vital signs, vital signs. Will you pay attention to your vital signs? I know you, Dr. Lovelace talked to you guys, I guess, yesterday and kind of made a big deal about that, which I'm glad he did. I think, you know, vital signs are very nuanced. You know, I don't typically like to discharge people with abnormal vital signs. Sometimes you have to, but I think you need to make a case. You know, somebody come in who's an asthmatic and you just gave, 20 milligrams of albuterol to and is feeling much better and has a normal respiratory rate and sat in 100% and says they feel great, their heart rate's 130, you're nothing you can do about that. You're going to have to wait there for hours for that to come down before it can come back. So you're going to have to discharge that person with heart rate 130. But you just need to make a case for why you did that. I think somebody came up here and talked about some 2-year-old with a high heart rate and a fever. I discharge those people all the time. You're not going to be able to bring down every 2-year-old with a viral illness that has a 104-degree fever and whose heart rate now 220 was obviously crazy, but has a heart rate in the 160s, 170s. But you need to be, so this piece of the puzzle, right? Not one piece makes a diagnosis. You write in there, it's like, hey, that infant was, breastfeeding from mom, was smiling and playful on exam. His exam findings were stone cold normal. He was, active and everything, didn't have a rash. I don't think it's this, I don't think it's that, arrange close follow-up. So there are times where you can still do that, but vital signs play a big key in your differential diagnosis building. So there's a difference between somebody who has chest pain and shortness of breath, who has a heart rate of 130 versus 80, right? There's a difference between a SAT at 88 and 100, a fever of 104 and 98, right? So why would we not want to focus on that, correct? But I promise you, one of you guys, I don't know however many you go to rotate with me, you're going to come back, you're going to present a patient, like, okay, what are the vital signs? You can give me this like blank stare, and I'm just going to rip you a new one, but it's all right. All right. Exam findings continued. Epidemiology, so sometimes, not all the time, but sometimes we can use epidemiology to help guide and rule out or rule in diagnoses. So pyloric stenosis, right? Males aged 3 to 5 weeks, uncommon after 12 weeks. You get a 6-month-old, mom comes in, says they have, projectile vomiting. They vomited, they went 38 feet and set a new world record, and she's really worried about this, that, and the other. Well, okay, that's great, but it's not pyloric stenosis at 6 months, right? Intussusception, same thing, 3-month-old after 6 years. Looking at those age ranges and knowing those things is helpful to figure out what you need to start worrying about, especially in kids, because kids are very difficult because they can't tell you exactly what's going on, so you have to rely on the parents, which is difficult sometimes. MI is real big, risk stratification, things like that. Sore throat, old people usually don't get strep. Okay, helpful tools. We're not going to go over all of these, but I do expect you to... Yeah, I know this kind of sucks. I'm not going to go over them, but I do expect you to know them all, so enjoy studying. But they will help you. Every single one of these I use almost every single day, and they're wonderful, and they're great ways to document, and they're helpful. I don't like to use my brain as much as I have to. I like to think as little as possible. These help you think as little as possible because smarter people than you and me have done the thinking for you and put it into a little algorithm for you, and so that you can help rule in and rule out different conditions, right? Nexus criteria for C-spine injury, PERC rule, I use it all the time for PE, Centaur criteria, strep throat, Wesley Croup score, and all these stuff's on MD Calc. I would recommend every single person downloading MD Calc. Like, that's it. I use it all the time. It's super easy to use, and it's got way more helpful tools than just that, and they're kind of help point you in one direction or the other. PCARN for pediatric head injuries. Those are all real good things. So, I mean, just look them up. You don't necessarily have to memorize these specific, everything that goes into them, but I do expect you to know at least what they're used for. Know that PCARN is used for ruling out needing a head CT for a pediatric head injury. Knowing the PERC rule is helpful in ruling out a pulmonary That's just PD.
Embolism.
Excuse me. Yeah, so look these up, know about them. You don't have to know specifically. I don't know them. I don't know all the criteria specifically in them, but that's what MD Calc's for. Okay. Yeah, that's perfect. It usually takes before this. It took me about an hour to get through this first part. And we just did it in 20 minutes. I'm super happy. You guys have any questions about what we just went over here? I mean, this stuff was very basic stuff. You should have known it all. I mean, these things right here are really helpful. So look those up on your off time. I think those are very helpful. Any questions? Nope. Okay. So we're going to go on to our case studies. And so how I do these is I'm going to present a case, and we'll kind of work through this first one, and we're going to work through it together, so audience participation is required. If you don't participate, you guys are going to get 0 out of this. And we're going to work through developing a differential diagnosis, and then ruling in or ruling out those diseases based on the information that I provide to you. Now, I'm only going to provide to you information that you ask for. If you don't ask for it, you're not going to get it like in real life. The only thing that I do spoon feed you is physical exam and vital signs and things like that, because it would take a very long time where we wouldn't be able to get through many patient cases if I had to ask you guys to ask me about, exam findings and things like that. Okay. Are we ready? Are we excited? That doesn't sound very excited. Okay. Okay. So here's our differential builder, most common, most deadly. In our first case, so a 26-year-old female presents with acute complaint of right-sided abdominal pain for the past 3 days that has been worsening. So right off the bat, only information you presented, let's start building our differential. When I walk into a room, just based on their chief complaint, I already have like 10 or 12 things that are possibilities on there. And so that's what you need to start going on. And then as I start to present you with more information, we'll start adding or subtracting to it, depending on what we like. Okay. Any possible diagnosis? Right-sided abdominal pain for the past 3 days has been worsening.
Kidney stones.
So after you'll probably put most deadly. And pregnancy, where do we want to put that? Pregnant, okay. What else? Chole.
Ovarian cyst.
Ovarian cyst.
Name it and tell him which column to put it in.
Yeah.
I think ectopic pregnancy because that's the one they're most deadly.
Yep.
Do people die from ectopic pregnancies?
Yes.
Sure they do.
Right into it.
Anything else?
Constipation is fine.
Constipation, ah, girl.
Ovarian cancer.
And a 26-year-old? Hey, we'll put it up there. I doubt that's what it is, but who knows? Weirder things have happened before. Can't hear you.
Pelvic inflammatory disease.
PID?
Yes.
Like I said, some of these have some overlap. So just because, cholecystitis nowadays is not going to be one of your most deadly diseases. That's probably a more common and easily correctable disease. I guess it's most deadly if you miss it and don't do it. But just because I put it in one column doesn't mean that it probably can't go in the others. Obviously, no one died of constipation.
IBD. IBD.
IBD.
Kidney stone.
Kidney stone.
Pancreatitis, most common.
I'll put that over there because sometimes pancreatitis can be deadly. But I mean, that not saying that those aren't over things, but how bad it is.
STI.
STI. Good. Okay. Let's continue. So now her pain is constant, but seems to be getting worse sometimes. She has some nausea, but no vomiting, diarrhea, or constipation. Has some vaginal spotting, but thinks that's just her period. No painful urination, denies any fever, chills, recent illness. She has no significant past medical history. She works as a stay-at-home mom. She denies any ETOH or tobacco or drugs. Okay, now with that presentation there, do we want to add or subtract anything from our list of differential? You want to subtract constipation? Okay. Sorry? Take off the IBD? Sure. You want to add anything? UTI. All right. Most common? See about 10 billion times a day?
That's a good one. What about gastroenteritis?
Gastroenteritis.
Although that's not the Oh, no. I mean,
Shouldn't have any nausea, vomiting, diarrhea. I don't know how you make a case for that.
Yeah, I think it'll
Put it
be.
up there.
I think it's nice.
Take it back. All right, we put it out there and we take it off. Now it's easy. Anything else? Okay. Here are vital signs. So heart rate 104, I mean, classically tacky, over 100, but not bad. Temps 99, that's not a fever. Fever is anything over 38 degrees Celsius.
Which is
101.4.
100.94. Yeah. 100.94.
Lots of that. Okay, so she has right lower quadrant tenderness, mild to moderate, no rebound. She's normal bowel sounds. Everything else is fairly normal in her exam. Epidemiology is probably not going to help us much for female abdominal pain. Anything we want to add or subtract based on her physical exam and vital signs?
diverticulitis.
Diverticulitis. Okay.
Take off pancreatitis.
Do what?
Take off pancreatitis.
Take off pancreatitis.
Doesn't have a fever.
Do you have to have fever to have pancreatitis?
Might go lower on your differential, but it's not going to come completely off.
Wouldn't the negative rebound tenderness rule out apples?
Sorry?
Wouldn't the negative rebound tenderness rule out appendicitis?
You want to take it off?
Yeah.
No.
No.
Okay. What's your name?
Sarah Beth?
Sarah Beth. Sarah Beth is so confident in her physical exam skills that she can touch a 26-year-old female's abdomen and know that she does not have appendicitis.
In all fairness, I did diagnose my brother-in-law with appendicitis a couple of weeks ago.
That's good. But you missed hers.
She's doing phone medicine on this one.
Let's keep it on there, Sarah Beth, just for the hell of it. Okay, anything else? That's fine. Okay, now labs. Do you guys want to order any labs?
What?
Okay, she wants to do a UA, pregnancy,
CBC, CMP.
CBC, CMP. Why are we ordering those two?
She's anemic.
White blood cells, okay, for the CBC.
And
If they have an elevated white blood cell count, does that make your diagnosis?
No.
Does that rule anything out? No, no. Does it help point you in a direction because it's one small piece of a puzzle? Yes. Excellent. CMP, what are we ordering that for? Liver, kidney functions. I mean, she is having right lower quadrant abdominal pain, but, you know, it could be referred from her gallbladder. So maybe we need to see some liver enzymes there. I'm not going to give you a hard time on that. Okay, anything else? Lipase. Okay. Why are we ordering all of these? Are you guys arbitrarily yelling those things out? Or is there a reason behind them? And what are you using to justify that reason? Good. Okay. Excellent. So we're using this to justify this. We're not shotgunning labs, right? I'll order whatever you want to order, but let's have a reason for it. So CBC, we're looking for our API and our chole, CNP here, ectopic, UA pregnancy, ovarian cancer, we haven't ordered any of that, pancreatitis, phenolipase, right? Haven't ordered anything for PID yet, haven't ordered anything for an ovarian cyst. Diverticulitis, I mean, CBC may kind of help point you in a direction to get some kind of imaging, right? STI, haven't ordered anything for that. UTI, we got a UA. So we're using our differential we have built to order lab tests. So a lot of times I'll ask these students, like, well, what do you want to order? And I kind of get this blank stare, which is fine, and they have a hard time coming up with what to order. What do I need to do? Well, take a step back. Make your differential. Rule in or rule out diseases based on what you order. Okay? Is there anything else we want to order here? Amylase? I don't know where that's at.
Alcohol?
Your sample for the STIs.
Okay. What do you want to order?
Gonorrhea or chlamydia.
Where does gonorrhea and chlamydia lie in the tract of a female? Is it in their bladder?
No.
Is it in their urethra? Where is it in there?
When you do a passenger.
It's where?
Yeah.
Cervix, vagina, right?
Oh, sorry.
Is this urine GC chlamydia test going to help diagnose? I mean, you can get that sometimes, you can get away with it, but that's not the best for a female. You need to do a pelvic, you need to do swabs. For a guy, there's only one way for that to come in and out, and that's through his urethra, so you can get away with ordering the urine, and you don't have to do the little Q-tip unless you're just mad at him. Which I know people do sometimes. I particularly don't like to just sit there and do that to dudes, because it doesn't do anything for me. So I just order the urine. But for females, you need to do the pelvic. Okay, anything else? So we've done labs.
Can we get alcohol as well?
Alkaphos.
Yeah.
Do we have to order that specifically?
Is it part of CMP?
Is it? I don't
I'm
know.
asking you.
You're the one ordering it.
Well,
I'm not
I
here to
want
answer
to double
questions, I'm here to
order it.
write stuff down. Class, is alkaphos part of the CNP? Not a lot of head nods. Maybe you should know what components of the lab that you're ordering. Answer your question is yes, it is in there. Anything else? Okay. Do you guys want to order any radiological imaging? Ultrasound of what?
Right.
Ovaries.
You want to order? Okay. There's no such thing as an ultrasound of an ovary. There's a pelvic ultrasound. There's a ultrasound specifically for an appendix, though it's very low yield, especially in an adult. There's ultrasounds of the gallbladder and liver. What do you guys want to order?
Pelvic ultrasound.
Pelvic ultrasound, okay. What are you looking for? Is she pregnant?
We don't know.
We don't know.
Do you want to call in the ultrasound tech
No.
to do an ultrasound on somebody you don't even know if they're pregnant? It can be look pretty embarrassing if they're not pregnant and you order an ultrasound. Why don't we hold off on that for right now? Any other radiological exams you guys want to order? That's fine. You guys want to wait? I'm going to give you the results of them. Do you guys want to order any treatments for right now? No? I mean, I guess just let her ride around in pain. That's fine. Okay. So her CBC, she got a white count of 14,000. Her platelets are 255. And her H&H 11.6 and 33. Can you guys all see this well enough? Good enough? Do I need to write it bigger? I'll write it bigger because this is going to be important.
Can you write it bigger?
Yeah.
There you go.
UA had, where are we at here? 3 red blood cells, had 20 to 50 white blood cells, and was Luke esterase positive. Okay? The results of her pregnancy test, she was pregnant. Her lipase was normal. And instead of me writing out her entire CMP like we did there, we'll just say it was normal as well. Normal kidney function, everything else was normal. Okay, now that we have the results of this, can we rule in or rule out any of these other conditions? We'll rule in pregnancy, sure. UTI?
It still could be ectopic.
It can still be ectopic.
Ectopic is still possible.
Sure. Now she's pregnant, sure.
Ovarian cancer.
Anything else?
Did we get the GC chlamydia results?
No, those take 3 days,
Oh.
because they have to be cultured. Okay. And what do we want to do now? A pelvic, like a pelvic exam, a pelvic ultrasound, okay? Do we want to do anything else? Pelvic ultrasound, do we want to do any treatments?
What's her pain level?
You guys are cold blooded. She hurts, man. She came in here.
On a scale of?
22.
Can we give
I mean, we said that her right lower quadrant was mild to moderate. I would say moderate abdominal pain is hurting.
Can we give some Tylenol? Cipro right now, ciprofloxacin.
Give her Cipro? Sure. Anything else? Okay. All right, so the result of her ultrasound showed a 4.5 centimeter right ovarian mass. And she got her Cipro, but it didn't do anything for her pain. Oh, yeah, that's weird. Okay.
On her ultrasound, did you do abdominal,
This is a pelvic.
over abdominal ultrasound or transvaginal?
They ordered a pelvic, so it was not transvaginal.
Oh.
Transvaginal.
No.
Okay, we got the transvaginal and it showed the same thing.
Tylenol, please.
Can you what?
Can we have some Tylenol?
Sure.
How's that make her feel?
Didn't help roll. Okay, now we have those results. What do we want to do?
HCG.
Her HCG was positive on her urine.
Don't you do the levels for ectopic?
Do you want to do a level?
Yes.
Okay, what is that called?
Serial?
Beta HCG. Anything else you want to do? Okay. Her beta HCG was 2,500. We want to do anything else?
We want to scan with analysis. We have to scan with analysis.
Scan what?
Scan the mass.
You're going to have to speak up, man. I can't hear you.
But scan the mass.
Scan the mass.
Scan, we did, I mean, that's your report. She's 4.5 centimeter right ovarian mass. That is your scan, that is your report. That's what you're going to get.
Can we order CA 125 to rule out the cancer, ovarian cystic ovarian
Sure.
cancer?
That gets sent off to the Mayo Clinic. It'll be back in a week. All right. What do we do now?
Can we see the gestational sac?
refer to.
gestational sac in an ovary? No, we see no gestational sac. She's 4.5 centimeter right ovarian
In
mass.
the uterus.
Refer to guide.
Yeah.
And you did a transvaginal, so is there any components of a pregnancy?
There's
Yes.
no IUP.
Oh, okay, okay.
Intrauterine pregnancy.
So let's give her some tramadol for the patient.
Okay,
Oh, yeah.
Because she has, we want the dead water.
okay.
Yeah, and maybe.
Let me give you guys a quick update on her exam. Her pain is now worse. Her heart rate is 125. Her blood pressure is 90/50.
Uh-oh.
And she's having increased vaginal bleeding.
She needs surgery.
What surgeon?
The one to take out the.
Who
And
does
who would
that?
that be?
Obstetrician.
An OB? Okay, so are we going to call this an ectopic pregnancy? Is that what our diagnosis is?
Right now, it's
Yes.
Yes.
No, she has no.
All right. Yeah, I mean, this should be,
Yes.
guys, man, this was the easy one.
Yeah.
This is the one I spoon fed to you. This is slam dunk. She has positive serum beta HCG over 1500, right? She's a 4.5 centimeter right ovarian mass with no intrauterine pregnancy. What do you think's causing that? The ectopic. It's not her ovarian cancer. It's certainly not her urinary tract infection. Right? Ectopic pregnancy. Disposition. What do we want to do with her? Do we discharge her? Do we admit her? Admit her. We call the OB service. Right? Stat, because now she's hemorrhaging internally because we kind of ho-hummed around this thing a little bit. That's fine.
How do you want to address her vitals? How are you going to fix her? Because you're certainly not going to.
Yeah, do you want to do any treatments?
Hydration.
Sorry?
IV fluid.
IV fluids? What kind of, well, all right. You want to do IV fluids and stuff like that. We'll get into that IV fluids thing in another case because I got a whole soapbox that I want to get on and talk to you guys about that. Okay.
So the biggest lesson was the level of her beta HCG. Make sure you're ordering quantitative and knowing when her last menstrual period was so that you know exactly how far along she should have been, as well as your transvaginal ultrasound had no intrauterine products in the uterus.
What's the one thing that we missed and we didn't order? Not a life-threatening miss, but still a miss.
EKG?
No. Blood typing. You need to see what her ABO-RH type is. Because if she's negative, she's going to be hemoglobin because she's bleeding and pregnant. Right. I'm not going to give you a hard time about that because every
Don't
month
forget
is
the
every
Rogaine.
single year.
As well, as far as thinking, is she positive or negative?
Okay, so the key to this one, like your professor said, always get a pregnancy test on women of childbearing age. Always, 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 always. There's zero excuse. The only reason why you don't need to get a pregnancy test is if they don't have a uterus. There's physically no uterus. Now you'll understand in hearing me correctly when I say uterus only. I didn't say anything about having a tubal or having their ovary removed or whatever. I've personally seen 3 positive pregnancies that people that had tubals.
Happens all the time.
If they have a uterus, it's actually 1 in like 2,500. It's pretty common. If they have a uterus, if they don't have a uterus, you don't need a urine pregnancy test. If they're between the ages of 7 and 65, order a frequent pregnancy test. It should be reflex. It should be reflex. The lab should call you or your nurses and say, hey, do you really want to order a pregnancy test? This woman has no reproductive organs. And you're like, oh, okay, well maybe not. It should be that bad because you reflex it on everybody. Every single person of childbearing age that has a uterus gets a pregnancy test. All of them. Always. Doesn't matter if you get a urine, you get a pregnancy test. Right? That's the key point to that. Okay. Now we're going to start working through this a little bit faster. I'm going to give you the whole thing because that one took us a little bit longer than I expected. A 65-year-old male presents with cough and weakness, okay? Shortness of breath and weakness, been going on 2 days, progressively worsening, generalized weakness. He's a resident of a local nursing home, his previous history of a CVA, and has kind of altered at baseline, and is not fully participatory in his own HPI. Nursing home reports, he is usually up and about ambulatory, but over the past couple days he's not been wanting to get up, not wanting to move around. He has a history of hypertension, DM, vascular dementia, and cancer. We don't know what, because the nursing home gave us a shitty report. Physical exam, he's altered, he does not answer questions, follows some commands. He's scattered bronchi, he's a little tachycardic. His abdomen's fairly benign, he has a bit of a sluggish Hcap refill, his heart rate's 115. Got kind of a softer blood pressure, 95/68, not necessarily hypotensive, but kind of soft. You don't know what he normally runs. And a temp of 38.1 Celsius. Okay. Most common, most deadly. Pneumonia. We're going to put that over here just based on his presentation, but that's one that's going to go on both sides. Anything else? Heart failure. Didn't have a history of congestive heart failure, but that doesn't mean that he doesn't have it now. PE. Can PE cause you to have like a subtle fever? Yeah? Yeah, you can. It can sometimes cause you to have just a little kind of low-grade fever. Flu. Sure. I just want to put that over there since there's enough people over there. But it's good that you guys are listing this most deadly cause, because that's what you need. That's in the emergency department. I don't give a crap if I miss some most common cause of something that's fairly benign and is not going to cause any problems. I don't care if I misdiagnose rhinosinusitis with bronchitis in a normal person. That's not going to be that big a deal for me. It's going to be a big deal if I miss a heart failure, if I miss a PE. So we need to make sure that this is filled up to its brim. But then, obviously, we want to get the diagnosis right because we care about our job. But we want to make sure that no one dies because we are done. Which happens all the time. People die because we are dumb. No one deserves to die because we are dumb. Right? Okay. Cancer? Sure, lung cancer. I mean, he's got a history of cancer already, so I guess he maybe has lung cancer.
TB, tuberculosis, TB. It's very uncommon.
TB. I would put that in your like super uncommon zebra.
That's sepsis?
It's definitely not.
Sepsis. Bronchitis, sure. We'll just put upper respiratory, and we'll kind of throw all that together. Bronchitis, anything you can think of that's in the upper respiratory tract, we'll just throw that all together.
Common cold.
Anything else?
Sure.
I mean, he has a history of a stroke, and he's kind of altered. I mean, I guess he could be having worsening of a stroke. I mean, I'm not going to give you a hard time about that.
UTI.
UTI, good. I'm going to put that over here just based on his presentation, but this would go on both sides. I think it's fairly safe to assume that most old people from the nursing home have a UTI, whether it's diagnosed or not. Ketoacidosis. I don't even know where to put that, but we'll put it over here. Any particular source from that ketoacidosis?
Diabetes.
Okay, so DK. And if this guy had a history of he does go in. Cool.
What about
Anything else?
delirium because he's altered and not paying attention?
Sure. I think we can already say that he has delirium. Diagnosis done. There you go. Got one of them.
Could you say dehydration?
Dehydration, okay.
Anemia?
Anemia.
So you have asthma.
Asthma, we'll just lump that in right here. Okay. I think we got a fairly good enough differential here. What do we want to order? Labs.
D-dimer.
D-dimer. Okay? Rapid flu.
Chest X-ray. CSR.
Sorry,
Chest X-ray.
chest X-ray. We're going to save that for radiology.
UA.
UA.
CBC,
CBC.
CMP.
CMP. Troponin. Tell me, why did you order troponin?
Kidney.
Do what?
Involved in sepsis.
Can be involved in sepsis. If he has a negative troponin, does that mean he does not have sepsis?
No.
He has a positive troponin, does that mean he has sepsis?
No.
Okay, so why are we ordering that?
Elderly can present heart attacks differently.
Elderly people present with heart attacks differently. Very good. Tell me, is heart attack on our list of differential?
No.
Why do we order it then?
Because we're about to add it.
Very good. You can order troponin all day long with some old guy who's weak and short of breath.
What else do you want?
EKG.
EKG, we'll save that for special tests. But I will write it down for you. Right now we're focused on lab work. Troponin, okay, what else? BNP for the, sure. Anything else?
Why did you guys say you needed the CMP?
Are we done? Special test, EKG. So special test for me is basically EKG. I mean, there's like, you want to tilt him or do orthostatic hypotension, orthostatic vital signs or do something weird. We just kind of put that under EKG because it doesn't really fall under radiology or labs for me. Okay, so radiology, we said chest X-ray, very good. What kind of chest X-ray do you want? A 2U lateral? Okay. It's going to be kind of hard to get a lateral in some old dude who doesn't stand up and can't follow directions, but that's a good answer. So 1 view is no view, 2 view is the perfect, right? But in a lot of cases, you can't get it. You can't get a lateral on some of these people that are old or can't move or can't stand or do anything like that. You have to suffice with just PA. Anything else? Okay. And treatments. Do we want to order any treatments for this gentleman?
Oxygen. Fluid.
Is he hypoxic?
Shorter run.
It's not in there, but his oxygen saturations will say is 93%.
Yeah.
Wow.
Yeah, you want a face mask, you want to use a cannula. Face mask, okay. How much is it? You want a non-rebreather or just a simple face mask?
Cannula.
Sure, we can do nasal cannula. How much do you want?
2.
2 what?
Liters.
Per? Anything else? Fluids, okay. What do you want? How much fluids do you want to give him?
Do we need to hear your soapbox first?
No. Soapbox comes after when you get it wrong.
So what do you consider as far as what type of fluid you want to use?
Normal state. Hypertonic.
Hypertonic?
No.
Oh.
But what are you looking at to consider which ones you're going to use?
His like is he volume depleted or volume overload? Look at his sodium.
So before you even look at labs, what in his presentation up there?
His blood
pressure. Blood pressure, but
That's okay. We'll get to that at the end. These lectures are designed to be difficult to get you guys thinking, and we tee it all together in the end. So don't feel bad, because this happens every 6 years, every time I give it, both courses. Okay, fluids. What fluids do we want to give?
Let's hold off on the fluids because he has heart failure.
Okay, you want to hold off on the fluids. Okay. Anything else?
But we don't know, he doesn't have heart failure, does he?
Well, we
don't
know,
know,
right?
right?
It's not on his past medical history, no.
What about,
Maybe give him an aspirin.
An aspirin, okay. We'll say he can still swallow something, just so we can give it to him. He didn't aspirate on it. Okay, so we've done those two things here. I'm going to say the D-dimer is negative, so I don't have to go through that whole bit. But remind me to talk to you guys about age-adjusted D-dimer. Write that down, look it up. That's newer. When I say newer, it's like years old. Newer medicine that people don't practice a whole lot. Age-adjusted D-dimer. We're going to say it's negative, but still look into age-adjusted D-dimer and how to interpret that, because that's very important when you're talking about ruling in or ruling out PEs. Okay, his flu is negative. His UA was negative. His CVC, let's see here, where am I? You guys know what this means whenever I'm writing it this way?
No.
Okay, well we will go over it. Hemoglobin, hematocrit, white blood cell, excuse me, platelets. This is a very kind of common nomogram for how you write down lab findings, and I'm fixing to do another one here for you. And this is another way to write down a BNP, okay? Since we're going to say his liver enzymes were normal. His troponin was, what was his troponin? I'm going to say was, we'll call it 0.15, which is elevated. His BNP was 500. This is a pro BNP. And so we'll say that that's just slightly elevated as well. Not stupid high, but slightly elevated. Okay. And his CMP is over here. Sodium, potassium, chloride, CO2, BUN, creatinine, glucose. Did everybody get that? Sodium, potassium, chloride, bicarb, BUN, creatinine, glucose. And I think I have answered all of these. His EKGs, we'll just say, was sinus tach at a rate of 128. And his chest x-ray showed bilateral pulmonary infiltrates. I need some more. Okay. And in the interim, in the 35 to 40 minutes it took to get all that stuff back, depending on where you work at, it usually takes about 35 to 40 minutes where I work at. We have a little bit faster lab turnaround time. Bigger hospitals in the city, you're looking at least an hour plus to get all of these labs back from a major institution. His vital signs are now 135 heart rate. His blood pressure is 80 over 30. His sats are now 88%. His respiratory rate's 27. And his temp is, what was it, 4? We'll call it 38.6.
Over how much time? An hour?
Yeah, like 35, 40 minutes. Okay. What do we want to do now? Do we want to order any more tests?
No.
Okay. Do you guys have a diagnosis?
Sepsis.
Sepsis. Okay. Is he severe sepsis?
He's on her way.
Haven't had that lecture. You just said you had a sepsis lecture.
We haven't learned the actual number for that, the details of the numbers to determine the criteria.
Oh, okay, okay.
comes
Well, then this,
Thursday.
and we'll just kind of walk ourselves through this. I'm not going to expect you guys to know things that you haven't learned yet. Okay. So we're going to talk about the treatment of sepsis here for the next 5 to 10 minutes, because this is very important. I would expect Dr. Lovelace would have discussed
We
some
went
of
through
this
it really, really fast.
really, really fast.
No notes.
No notes.
You have to take your own, that's how we learn.
Pull up your MD Calc. Everybody already downloaded it while I was talking about it, right?
I
Okay.
did it from cardiology.
Yeah.
What's your first clue for his sepsis?
Fever.
The fact that his fever went up that much in 45 minutes.
And?
We were getting the oxygen and the oxygen was like.
Yeah, crazy, huh? Okay. Now, I still go by Sears Criteria. Now, when you look up the most up-to-date literature on sepsis, you're going to find a whole bunch of different things, okay? And now, like the United Sepsis Congress of the World, whatever, are more going towards things called the SOFA criteria, sequential organ failure assessment. And then they try to add in this little QSOFA thing for the emergency department. Let me tell you, this QSOFA thing doesn't work. It's not validated in the emergency department. It works in critical care, the intensive care unit. That's where that was studied. And unfortunately, that's where SOFA was studied at. And there's a lot of bickering and debate on what the best criteria to diagnose and treat sepsis is. SOFA has very good specificity, meaning that if you are SOFA criteria positive, you do have sepsis, but it has low sensitivity, meaning you miss a certain number of sepsis. Now, I don't have the numbers memorized off the top of my head. I looked at them the other day. Next time I'll have to add them to this lecture. All right, and Sears, which we're fixing to go over, has a high sensitivity, but a low specificity, meaning it makes people seem like they have sepsis that really doesn't. Okay, and we're going to talk about how that comes into play when we talk about Sears criteria. Okay, can you guys read me off what Sears criteria is? Do you guys have that pulled up?
Yeah.
What is it?
Temperature above 38.
Temperature gradient 38C.
Or less than 36.
Good. Okay, so high or low. What else?
Heart rate greater than 90.
Heart rate greater than 90.
Respirations greater than 20.
Respiration greater than 20. What's the last one?
White count greater than 12 or less than 4.
Greater than 12, less than 4.
Or 10% bands.
Or 10% bands, exactly. Bands are a group of immature neutrophils, so you can just remember that from lab medicine. Okay, now tell me, based on these right here, does this patient have sepsis? Or, does this patient have Sears? Yes, he has a fever over 38, his heart rate's over 90, his respiratory rate's over 20, and he has greater than 12,000 white blood cell count because his white blood cell, I think, was 15 when I wrote it up there. Okay? So he has systemic inflammatory response syndrome. Now, what do you need for the diagnosis of sepsis?
Suspected infection? Suspected infection?
Suspected or present.
Or present.
So you have to have a source. Or suspected. You think somebody's bacteremic, but you can't wait for 28, wait to 2 or 3 days to culture out the blood. Yeah, I still think you can still call that sepsis because it's a suspected source, right? How many of these do you need to qualify for Sears?
Greater than 2. Or equal to, yes.
2. So either they're febrile and tachy or tachypnic and tachy or whatever here. Okay? Now here's where the specificity of Sears starts to drop. Your little 8-year-old girl with strep throat who has 102-degree fever and has a heart rate of 101, does she have Sears? No? Yeah. She has fever and tachycardia. Does she have a source of infection?
Yes.
Is your little girl with strep throat that's just chilling on the bed septic?
No.
There's your caveat, and there's your difficulty in the two of them. And I'm not going to go over SOFA because we don't have enough time. Maybe next year.
I do that tomorrow.
Perfect. Okay, we can talk more about the two of them and how those go in there, and about how SOFA criteria. And when you actually look at the criteria, you can see that if you meet the numbers and you're positive on it, dear God, you do have sepsis, because they're pretty crazy numbers. But you can still miss some, because not all people are as sick as what these numbers are telling you here. Okay? So that's why I still think Sears is the more dominant form to rule out, to get the diagnosis of sepsis. I would rather I would rather be wrong on sepsis, treat them for sepsis and it not be it, and they go home the next day, than miss sepsis and not get it. Yes?
How do you consider blood pressure through all this?
Is it in any of these?
No.
Is it in this?
Yeah.
Do you? Yeah, okay. Do you need to have low blood pressure to diagnose sepsis?
No.
Nope, absolutely not. This is very specific criteria. Now, when you're talking about severe sepsis, now this category has kind of gone out the wayside too, but I still want to talk about it so you guys are aware of it. But I think recently this year they've taken severe sepsis completely out of this category, and you're either now sepsis or septic shock. But so what is the criteria for severe sepsis? Elevated lactic acid level. Did we order lactic acid level?
No.
Sure didn't. Okay. What's next?
Systolic blood pressure.
Professor Reggie,
Or a drop of more than 40.
Systolic blood pressure less than 90. Anything else?
Or a drop of 40 or more in the systolic blood
40 from their baseline?
Yeah.
Right. Okay. Now, what do you need to diagnose septic shock?
Hypotension despite adequate fluid retention.
Okay, hypotension despite adequate fluids. Are you going to talk about fluids and stuff like that tomorrow in Boluses?
I know that Dr. Lovelace covers that some, but I haven't finished it because I'm going to update it. I can put that in.
Oh, we'll cover it right now because I think
Okay.
this is important, and we actually have enough time because we may start going through these a little bit faster. Okay. What's the so adequate fluid bolus? Can we see? Can anybody figure that one out for me? Adequate fluid bolus is 30 cc's per kilogram. That is your answer to how much fluids, and that's a bolus. I think it has to go in like over the first 4 hours or something like that, but I just let it ride. That's a bolus. Now personally, I think that these kind of little algorithmic roadmaps can be a little wrong sometimes. I think sometimes you don't need to give that much fluid to some people. I think some people require more. Now, are you going to give 30 cc per kilogram to somebody who has stage 4 congestive heart failure and who's septic? Probably not. Now, you're still trying to treat what kind of shock is sepsis? You guys had a shock lecture? Sepsis is a distributive shock, meaning you lose the tone of your vasculature, and so you lose the ability to distribute fluid to your vessels. So you need more fluid inside that contained space. So the answer to the treatment of most distributive shocks is fluids, and then vasopressors if needed, but you want to try fluids first. So 30 cc's per kilogram. Now what kind of fluids do you want to use? Okay, so you can use normal saline, which is not a wrong answer. I think that's a very common thing to use. But I think that there's a better thing to use, and that's lactated ringers. Lactated ringers is a more balanced fluid, and There's actually a few trials that just came out right now. You can write this down and look this up. It's called the SALTED, SALT-ED trial, SALTED trial. And that compared normal saline to lactated ringers and a whole bunch of different outcomes. And they found that lactated ringers is actually a little bit better and more safe, has less side effects than normal saline does. So normal saline has this huge amount of chloride, right? And that's an anion. So when you're talking about metabolic acidosis and anion gap acidosis, all of a sudden you have your, I don't know, 180 kilogram septic patient that you're just giving a shit ton of fluids to. You're going to drive up this chloride level a ton because of its component and concentration in normal saline. So you can increase their metabolic acidosis by giving them a chloride acidosis, right? You're not going to get that with LR. LR is a very balanced solution. It has the same osmolality and osmolarity as your blood does. So you can look up and see what the different concentrations of sodium in the millimoles and do the calculations that you want. But it's a more balanced fluid. Okay? So septic shock is hypotension refractory to fluid bolus. So he's hypotensive even after we give this 30 cc's per kilogram fluid bolus. That's when you need to go into pressors. Okay? And we won't talk about that because we don't have enough time, but safe to say norepi is going to be the right answer for almost any kind of pressure that you can ask for in any condition. For heart failure, for MI, for sepsis, whatever. Now there are a few conditions where I think there's more appropriate pressures, like in anaphylactic shock. I think epinephrine drip is probably a little bit better than a norepinephrine drip, but I think norepinephrine is going to be your right answer for everything. So if it's like, hey, you want to put them on pressure, what do you want to use? Norepi, levofed. Okay. So, fluid bolus. If we'd have done that from the start, probably he wouldn't be in septic shock right now. So the key to treating sepsis is early recognition. And that's why I like the Sears criteria better. It is more sensitive than the SOFA criteria is. Now, you might diagnose somebody with sepsis and they not really have it, great. But like I said, you'd hate for all of a sudden these people to start tanking because you're not missing it. Okay? Fluid boluses, Sears and sepsis criteria here. Remember that severe sepsis is no longer an actual thing, but just keep it in the back of your head as far as the criteria goes. And then your septic shock is contrary to this fluid bolus. Okay? What antibiotic? So he has pneumonia and he has sepsis, and now he's in septic shock. We gave him a fluid bolus. He's got to turn around a little bit. Blood pressures are coming up. He's not looking like he's about to die this second. What antibiotic do we want to give him?
What are his allergies?
No allergies.
Vancomycin.
Vanc. And anything else? What does Vanc cover?
Gram-positive.
Gram-positives, and what's the most important one that you're covering with Vanc? Because there's a lot of other MRSA. So yeah, gram-positives, but the most important thing you're using Vanc for is to cover for MRSA. So I guess we better hope that his pneumonia is from anything other than gram-positive MRSA.
Ceftriaxone.
Rocephin. Okay, well, you guys are kind of throwing out stuff, and that's fine. You need to go back through and look at your antibiotic treatments for Hcap, hospital, acquired pneumonia. That's not only for the hospital, that also, or I'm sorry, healthcare associated pneumonia. Hcap, healthcare associated pneumonia. Nursing home is healthcare, so you need to treat for Hcap. And that would be like a Zosyn. And cephalosporin's not wrong. You do, I do something a little bit more of a gram-negative coverage, like cefepime, fourth generation cephalosporin, than your Rocephin. I think it has a little bit more, as the cephalosporins start to go up in class, you kind of start to get more of a gram-negative coverage, if I remember correctly, a long time ago. But these two are your go-tos here, you know, cefepime, you get a penicillin allergy. Then obviously there's a ton more different combinations that can be used depending on your allergies, okay? And blood cultures. Get your blood cultures. If you're not a little kid, if you have a fever and you're getting blood, get blood cultures. I mean, that's just kind of what you need to do. Now, I can go on a whole huge big rant about the futility of blood cultures and everybody that has pneumonia and COPD and how we're overusing them, and like 90% of them come back negative, and there's no point unless you think that they're septicemic or bacteremic. I think that there's a really good chance this guy's bacteremic given his presentation. But standard of care practice, just get your blood cultures if you have a fever.
Should we also do a sputum culture because he's coughing?
If you can get it, yeah, absolutely. Sputum culture, you can get a respiratory pathogen panel, all that stuff's not going to hurt on this guy. Yeah, absolutely. Okay, so take-home points is understanding your criteria and diagnosing your sepsis. Now, you guys are going to talk about SOFA and Q-SOFA tomorrow, and it's good to know those things. I mean, you need. I'm not saying you don't need to know one or the other, or like I said, one or the other is better than the other. I think there's not a general consensus on which one is better or which one is worse. They both have their positives and negatives in regard to your specificity and sensitivity. I think Sears Criteria is a little bit better. It's easier to diagnose. The SOFA criteria, when you guys are going to talk about it, you know, you have to do like this big calculation of partial pressures of oxygen, and it takes into account bilirubin and all this other stuff that you have to add up to that gets you to that point, which I think is sometimes a little arduous. And then the Q-SOFA, you can just blow that out the water. Q-SOFA has been proven not to be good in the emergency department setting. Now, in the ICU setting where they tested it, sure, that's going to be great for recognition of early sepsis. But Q-SOFA is like, I don't know, to me it's kind of like a no-brainer dumb thing. I think it's 3 criteria, like altered mental status, blood pressure lower than 90, and like a respiratory rate of like 30 or something. Is like, well, yeah, no shit. If they have any of those, they're probably not in good shape. You know, I didn't need that. Those 3 things to help tell me that this person's not doing well. You know, a person who's altered has blood pressure lower than 90. Got it.
Can you explain? Oh, sorry. Checking calcitonin and sepsis. I can't. Was it Dr. Lovelace that mentioned that issue?
Yeah. So procalcitonin is a good indicator for sepsis and septic shock. There's varying levels. And now, I'm not an internal medicine doctor or hospitalist, but I do know that they like to monitor those and have those go down, trend those down. So procalcitonin is a good one to get back. Procalcitonin is also sometimes good for determining bacterial versus viral etiologies, especially, or bacterial versus non-bacterial etiologies, especially if you have somebody who, like say, is coughing and short of breath, and you know, their lungs look a little fluffy, but they have a history of CHF, but they have a 14,000 white count, but they don't have a fever, but they also are a little tachycardic. Like, you know, is it CHF or is it pneumonia sepsis? Procalcitonin is also helpful in determining between those two. Gotta get your lactic acid. Okay, does anybody have any more questions over that? Early recognition of sepsis, fluid boluses, blood cultures, and antibiotics. Those 4 things are Centers for Medicaid Services quality core measures. You have to do them. You have to give a fluid bolus of 30 cc's per kilo within the first 4 hours. You have to get blood cultures and antibiotics in within the first 3 hours. Like you have to. And if your hospital wants to get paid and survive, you have to do those things. But I can tell you, if you look in the actual literature and the emergency medicine community, sepsis is a very contested. We don't disagree that sepsis is a real thing, but trying to find the right thing to fit the emergency department is tough. Okay, I'm sorry we're probably not going to get a break today because we got to go through, and I think there's some good cases. We've got to at least do this one and then one more, I think. Yeah. Okay. So, 22-year-old male, nausea, vomiting over the past 8 to 12 hours, unable to keep any fluids or liquids down. He feels sick, so on and so forth. His vital signs a little tachy, blood pressure looks pretty good, respiratory is 28, it's at 98%. He's mild distressed male, got mild abdominal tenderness, no focality. He's tachypnic, but no distress, tachycardic, no other real significant findings. Smokes a pack a day. He denies drinking. Any 22-year-old said they don't drink. And especially he's kind of in a blue-collar job like a mechanic. I don't want to pigeonhole anybody, but I'm pretty sure he drinks. But he doesn't do any drugs. Okay, we're going to skip this portion, but I want you guys to think about it as you're ordering labs. Okay? What do we want to order? CBC. What are you looking for there?
White count.
Would it be anemia?
White count, anemia, actually, yeah, exactly. I mean, yeah. CMP. A lot of people forget about anemia. And that, in chest pain, shortness of breath, dizziness, anemia, man, that fits. That's like tied up in a bow when you give it to you and your blood levels come back low. So everybody wants to get a white count on CBC, but people forget about anemia and platelets and the other, components that you diagnose disease and stuff. Okay, CMP, so we're looking at electrolytes and liver enzymes. Got a little bit of belly pain, nausea, vomiting. Anything else?
Would you do lipase?
Lipase, I mean, he is vomiting. Flu. Oh, we said no past medical history, no surgeries. No history of surgeries or past medical history. Doesn't make any medicines.
Urine analysis.
UA. How often do young adult males who are normal get urinary tract infections? Uncommon, but still possible. There are other things in the UA that are helpful. Anything else? Okay, any special tests? Nope. Any radiology? Any radiology?
X-ray of the abdomen?
We'll talk about how I think X-ray of the abdomen is the most worthless test you could ever order in the emergency department.
You guys are welcome.
Hard stop. Hard stop. The most worthless test.
Yeah, write my name on that one.
K or C?
Oh, spell that. I want to see what you come up with.
Nope.
It's pretty close.
Yep, that's
Two letters.
ETOH level? Sure. I mean, you could be drunk, just lying to you. I mean, in the grand scheme of things, the people that lie to you typically lie more about drugs. They usually don't lie if they've been drinking, but,
A talk screen, maybe.
A talk screen?
Maybe as a mechanic, that's kind of.
Okay. What kind of talk screen do you want to order? Just the talk screen. Based on his physical exam and his history, is he presenting with a specific toxidrome that you're worried about? Does he have anticholinergic overdose? Is he suffering from a Tylenol overdose? Benzo?
After a carbon monoxide poisoning, if he's a mechanic and he's weak, dizzy, lightheaded, he could carbon monoxide, but how?
You can also be abducted by aliens.
Well, yeah, but how often, or how quick afterwards can you not test that, in the blood?
I mean, I think until it gets breathed out, when he's having symptoms, you would think that it'd be elevated. Well, what makes you, in that big net right there, think he has carbon monoxide poisoning?
Oh, she said mechanic, and
Okay.
I saw lighting.
Okay.
Mechanic.
I mean, not a bad thing to think, but I mean, that'd be more you're chasing towards zebras, especially in the fact that he, wasn't in a confined space. I didn't say that it was winter. He doesn't live in an old house. I mean, those are kind of more spoon-fed to you. Yes?
Is the glucose included on a CMP?
Is it?
Yes.
Yes.
Okay,
Your fish bones.
what else?
Have I given you guys the fish bones?
No.
I will get that.
Okay, abdominal x-ray. It was negative, Caitlin, but good try. Okay, treatments. We're going to give this guy any treatments. We're going to give him some Zofran. How much? In what round?
0.15 mg.
Oh, 8 milligrams. Does anybody want to do anything different?
Shout it out. Say we're like,
Suppository?
Yeah, that's what I was thinking. Yeah, suppository.
Okay.
How are you gonna give it? Sublingual.
He wants to give us sublingual. Anything else?
What? Fluids. 30.
Fluids. You want to give fluids to somebody who has a heart rate of 125 has been vomiting all day? Yeah, I would think so. What kind and how much?
Normophane.
Lactated ringers? Okay. How much? Is he septic?
No.
Does he meet sepsis criteria?
No.
Then why are you giving a kid that does not meet sepsis criteria sepsis dose fluids?
Give him a liter.
1 liter? Excellent. We're going to say bolus. Anything else?
Okay.
Okay. CBC, here we go. 15,000 white count, 16 and 45, and 330. Z2H level is normal. Sodium was 116. Okay, 2.6. Chloride was 108. Bicarb was 8. BN was 21. 1.3 ounce creatinine. His glucose was 485. Lipase was normal. His flu was negative. His urine had 3+ ketones and 1+ blood. Okay. Do we want to do anything else as far as labs or treatments? Labs. Do we want to order any labs? His blood sugar's already up there. It's 485. Is A1C?
is he undiagnosed?
I mean, is he?
Oh, for type 1.
Yeah. We'll be sure to let the primary care doctor know about his A1C and insulin level. Anything else? ABG. Why do we need an ABG? What do you guys think he has? DKA. What do you need to diagnose DKA? Diabetic, keto, acidosis. Do we have anything here saying he's acidotic? I mean, we do, but I'll let you guys know about that here in a little bit. So ABG, yeah, we said it. Yeah, bicarb. That tells you he's acidotic right there, but we don't have an actual pH. Okay, so his ABG is 7.1, 25, and 8. What do you guys see? Now, we'll talk a little bit about, if you rotate with me or if you're in the ER, we're talk the difference between ABG and venous blood gas. Not a big difference between the two. The biggest difference between the two is the measurement of your CO2. Once your CO2 starts to get super high, your your PCO2 starts to get super high, your venous blood gas starts to become a little bit less reliable. So whenever I think of an ABG, I think of more respiratory type conditions when I'm trying to measure a pH. Versus a venous, you can just get that straight from the lab draw. You don't have to do an arterial stick, an extra procedure. It's going to tell you all of these numbers are going to be pretty close. Now the pH is going to be a little bit different, but it's like not that much off. All right, and you'll see how this bicarb level and this bicarb level are identical and will be within a point or two. So you can tell just kind of right off the bat how acidotic somebody is just by getting a BMP without even looking at their gases, because that number and that number are the same. But you can't get an actual pH from it, right? But when somebody has a bicarb or a CO2 level, CO2 and bicarb are used interchangeably in your BMP. You can tell by that being low how acidotic they are. Okay, anything else you guys want to order lab-wise? You're working in New York Presbyterian. You have every lab available at your thing. You're supposed to.
I want to know what's causing this DKA. So, like, would you go ahead and order antibodies for type 1 diabetes?
Sure, they'll be back in about a month. Okay, so we got this. Treatments. What do we do for treatment? Do we want to give him any treatments?
Yes.
IV insulin. How much? How much insulin? How much insulin? Somebody just say something. 10 units, IV. Okay, anything else? We gave him a liter of fluid. We're going to give him any more, any less? We're going to give him anything else? Okay. We'll say 10 minutes after your new treatments were given, he went into ventricular tachycardia that was not responsive, and he died. Why did he die? I'm sorry?
His blood is still so
Okay. What does acidosis have to do with ventricular tachycardia? I'm not saying that it doesn't have anything to do with it. It absolutely has something to do
Okay.
with it.
So, do you remember, so Dr. McNeil talked about if you correct it too quickly, then
Correct
you get
what
like
too quickly?
encephalitis or something with the
Correct what too quickly?
the
Is blood
glucose.
Okay. You can get cerebral edema.
Yeah, encephalitis.
Will cerebral edema cause you to go into ventricular tachycardia?
You need potassium.
You need potassium.
You need potassium.
What do you need potassium for?
Your heart.
What does insulin do to potassium? Drives it into the cells. So we just took his 2.6 and made it, no, this is an arbitrary number, 0.6. Do you die from DKA because of hyperglycemia?
No.
What do you die from DKA from?
Electrolytes.
Electrolyte abnormality, and what else? It's already been said. Your cerebral edema can cause you to herniate. You're not going to die in the next 10 minutes. But that is something to think about. More specifically, your acidosis, your electrolytes, and then your just general dehydration. But that's going to come back to the acidosis. Your body has to function at a specific pH in order for cellular metabolism and cellular signaling to happen. If it goes below that, you die. Right? Cells can't signal, things don't work. Your heart has to have a certain level of potassium to make its muscle move. If that level goes up or down in wild fashions, you die. This is how people die from DKA. They do not die because their blood sugar is 485. So, in the treatment of DKA, what is the most important thing that you're doing for this patient to keep them from dying? Correcting electrolyte abnormalities if they have them, and correcting your underlying acidosis by fluid administration. Fluids, 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 fluids. I do not give a crap about what their blood sugar is until I think that they are adequately hydrated and their electrolytes are somewhat corrected. Now, am I saying that that is like a stepwise thing, that I don't do anything about their glucose until all these things are perfect? No. But it's a hierarchy. I care more about their fluid hydration status and electrolytes than I do this. Now, if this was 4.5, not bad. What do you think about this? What do you think about that number? It's low. Thank you. I was going to say something mean, but I'm not going to do it. I'm going to hold it back. It is low. Is it really low? Okay. Is it not really low as in the number? Is it truly low? You have to correct it. What is their corrected sodium based on their blood glucose? It's in MD Calc, you can correct it. His sodium's still a little bit low, but it's not as low as what you think. For the higher it goes above 200, it kind of drops it down like 1.6 or something like that. This is really important when you have people with hyperosmotic, non-ketotic syndrome, when their blood glucose is like 1,000. Right? Okay. Now let's go back to this 10 units of insulin nonsense. Okay? Don't do this, ever. If you have a preceptor that does it, fine. Just tell them to do it, or they can do it, that's fine, that's their own practice, whatever. Do not give 10 units of IV bolus insulin on people that are insulin naive. Okay? And even if they are somewhat insulin resistant, I still don't think bolus IV insulin is the right way to go, because it causes massive fluctuations in electrolytes and blood glucose. Correcting your blood glucose too fastly or too quick can cause cerebral edema. So you're taking a bunch of glucose and you're moving it into the cell from the insulin. Well, glucose is a solute. What is water going to do? That's when you have your cerebral swelling, when you have that massive influx. Okay? Now you want to do, make sure I get you this number right. What is the dose of insulin that you want to give for a drip in somebody with DKA? It's like 0.15 units per kilogram per hour. In a 70 kilogram person, it ends up being about 7 units an hour. Okay? Now don't write that number down, because I'm pulling that one off the top of my head, but I'm pretty sure it's 0.15 units per kilogram, but it'd be super fast to get it. This drip insulin is the way to go. It doesn't cause your massive shifts in electrolytes and glucose, but you're treating their underlying problem by getting glucose into the cells so the cells stop churning out ketones, causing the acidosis and causing the electrolyte abnormalities, okay? But this is a slow process. When I mean slow, I'm not talking about days, I'm talking about hours, right? This is a fast process. This is something you'll die quickly from. This is something that we need to correct, right? And LR, I think, is absolutely the best type of fluids, especially in this case when they're already metabolic acidosis and their chloride's already a little bit high anyways. I mean, you're talking massive amounts of fluids for this normal dude. We're probably 3 to 4 liters. You want to flush this dude out. I mean, I'm giving at least 3 liters and then reevaluate it to see how he does. Okay, you got to get all those ketones out. You got to reestablish the acid-base balance in the blood, and then make sure your electrolytes are okay. And then we start to work on the glucose. Right? Make sense?
Yes.
All right. Any questions over any of that? So I think take-home points on this one. IV push-dose insulin is bad. Bolus. Now, I'm not saying that it's bad in all the cases, because you get people in there that are on 200 units of Lantus every day and take 80 units of Novolog, you know, 4 times a day, you know, they can tolerate 10 units IV. They are so insulin insensitive that you could give them a ton of insulin, it wouldn't really do much for them. But in somebody who doesn't take insulin, who's now a new onset diabetic, is going to be a little bit more sensitive to it. How much does 1 unit of insulin drop the blood sugar in a normal person? Not insulin resistant, no underlying pathology. How much does 1 unit of insulin drop the blood sugar in a normal person? You guys just ordered insulin, but we don't know anything about it?
No, we don't.
It's about 35 to 50 milligrams per deciliter. So we gave that guy 10. So we'll say on the low end, we dropped him 350 milligrams per deciliter. I think his underlying blood sugar was like in the low 4s. So we dropped him almost 75% in, you know, 30 minutes or so. Because you really don't have, I don't think you really have that much in difference in peak and onset as far as absorption properties, because you're giving it directly into the blood. I mean, it's gonna start attaching itself to cells right off the bat. Insulin's a dangerous drug, and people forget about it a lot. And if you misuse it, you can do a lot of harm to people. People, like I said, people don't deserve to die because we're dumb, right? This is where we get smarter. Okay, any questions? All right, we'll bypass this one. It's kind of it's a zebra chaser, but it's kind of designed to make you think of a broad differential diagnosis. You can kind of read over that presentation. He ended up having Rocky Mountain spotted fever. In Oklahoma, it's actually more common here lately. It's bizarre. I've had like 6, 7, 8 cases this summer of Rocky Mountain spotted fever. And I mean, I can count the number of cases on one hand that I've seen the 4 years or 5 years previous to that. So it's kind of bizarre. I don't know, like the tick population is just going crazy or something or what. But anyways, okay. Case number 5, 56-year-old male, chronic neck pain. I'm gonna try to, well, let's breeze through this one in 10 minutes so we can get the last one in hopefully 10 minutes. Pain in the cervical spine, history, multi-level vertebral body fusion. His pain has been chronic for some time now. Again, he's had multiple neck surgeries, but it's worsened in the past 12 hours. Pain's mostly in the back of the neck, but hurts in the front of the neck with some pulling of the upper chest. Rising shortness of breath, headache, dizziness, nausea, vomiting. Professional history for hypertension and elevated cholesterol. Denies any of the good stuff. He works at a grocery store. Mild distress, slightly diaphoretic, tenderness to his cervical spine. All right. Labs.
CBC.
Okay, for what? You think he has an infection? Okay, does he have a fever? I didn't give you any vital signs. Vital signs are all stone cold normal. He has no history of IV drug abuse. His surgeries have been years ago. Do you think he just all of a sudden developed an osteomyelitis or an epidural abscess in the past 12 hours? And if he did, if you have a normal white blood cell count, does that mean that he doesn't have it at all? Okay. So well, we can still do it, but I don't think you get a whole lot of benefit from that. It's not going to, if you're thinking of an infection in his neck, hold on, you're the one that said it. Okay, good. If you're thinking of an infection of his neck, I mean, that's not a bad idea, but this isn't going to, if you're running this to help point you in any direction, I don't think it's going to help you much. If it's normal, that doesn't mean anything. If it's high, that doesn't really mean anything either. In fact, almost every epidural abscess and osteomyelitis that I've ever seen had stone cold normal blood work. And actually, if you look at the literature about osteomyelitis and epidural abscess, I think last time, because I gave a presentation over this, because we had one that was missed in our ER a couple of times. There is an average of 4 to 5 visits before diagnosis. So it gets missed 4 to 5 times before somebody decides to do an MRI and gets kept. So long story short, those are difficult diagnoses to make. And IV drug abuse would be your big factor right there. Those are one of the people that develop those most often. Okay, so CBC. Anything else? Okay. Any special tests? Any? No. That's for a physical exam. Any radiology? X-ray. X-ray what? C-spine. You think he broke his C-spine? Do you have any history of trauma? Does he have upper extremity radiculopathy?
He works at a local grocery store. What does he do?
He's a cashier. Is the C-spine going to show you anything about his discs?
No.
Is it going to show you anything about the nerve? Is it going to show you anything about the possible infection that he might or might have?
Do a CT.
Or MRI.
A CT or MRI, okay. I mean, you know, kind of going off the rails here. Well, the C-spine was normal. I mean, it showed multi-level vertebral body change, diffusion, some degenerative disc disease, poor spacing, things like that. Didn't show anything else. Any treatments?
Pain. Pain control.
How much you want to do for pain? How much and what?
What do I want to give?
Is he already on pain medicine, chronic pain medicine?
Yeah, let's say he's on Norco 10s, like 5 times a day.
Well,
2 5 times a day? Or 1
Yeah,
5
oh, yeah.
times a day?
Yeah, 2, 5 times a day. Yeah.
How do you know if he's coming, like, he could be a drug seeker? Or what's something that you look for?
Yeah, there's no real factors on that. It's a gut feeling. But then let me tell you about all this stuff with drug seeker here in about 3 minutes.
He's a drug seeker?
No, I'll tell you about like how to not how to determine, but I'll talk to you about how bad that is to think that way. Because you're fixing to find out here in 10 seconds.
Can we check at your phone?
Nope. Because I already started giving you guys way too much about it. So
She said it earlier.
I said it.
Where?
She didn't say it
we
loud
set
enough
up before the radiology.
I thought I was going to get you guys.
What is it?
Anything else?
EKG.
Yeah.
CRP. That it? Okay. EKG. His troponin was 1.2. His EKG showed ST depression in his lateral leads. Good job. What is the key? Okay, treatment. We'll talk about the keys after this. Treatment. So what do you guys think's going on? Your drug seeker is...
No, I don't,
I'm not saying you, I'm saying in general, because there's a good thing to learn from this
I'm the
case.
person who's always gonna believe them, so I'm scared.
Well, you're going to get burnt about 10,000 times on that, but that's okay. Okay. Treatment. He's got a positive troponin, and he's got ischemic changes on his EKG. Okay. Cath lab, is he having a STEMI? Does he have ST elevation? Do those people typically go emergently to the cath lab with no treatment in the emergency department? You go, hey, Mr. Cardiologist, I got this guy. He needs to go to the cath lab. Is there anything else we want to do for him? Okay. Yeah, I mean, he is having a heart attack, right? Anything else? Nitro? Sure. How much? You want a drip, sublingual, or patch? Sublingual, so you can do the 0.4 milligrams sublingual every 15 minutes times 3. Oxygen. You guys are almost there.
Dilaudid.
Dilaudid?
The good stuff. I'm looking at it's from your lecture.
Morphine, right?
Not morphine.
Okay. Can you guys see? You're cheating looking at my lecture, but that's fine. Anything else here that might spell the words Mona? Like your O or your N? Now, this is 100% right. You guys listened to my lecture, you got on my soapbox about Mona and how that's a dead acronym and forget about it. Don't ever do it again. He has normal oxygen levels, so he doesn't need oxygen. We definitely didn't give morphine, thank God, right? Because he's having an in-STEMI, he has 27% higher chance of mortality with that. We gave nitro, not bad, but what specifically about his EKG changes? Oh, excuse me. This should have said inferior, not lateral. We still want to give nitro with this? What about his EKG changes our management for the administration of nitro?
Don't give it because it can cause hypotension
Okay.
by decreasing stroke volume in the inferior leads.
Yeah. In patients that, so this is affecting the right ventricle in inferior MI, right ventricular dominant. How do we know for sure whether it's right-sided MI or not? What can we do to help us?
Let's see.
Can we get a right-sided EKG? I love that look. Yeah, a right-sided EKG. You take V4 through V6, and we'll just kind of make like a little person's chest here. I know my 3, 4, 5, 6. Excuse me. 3 through 6. And you transpose them over to the right side. 4, 5, 6. That gives you the electrical activity for the right side of the heart. And then you look for ischemic changes in those leads that you moved over. And if you do have ischemic changes, that means you're having a right-sided MI. There's preponderance of evidence telling you have a right-sided MI, and you may want to hold off on the nitro. If you move these over and they're normal, you can roll the dice with the nitro if you want. But to me, nitro doesn't offer any morbidity and mortality difference in STEMIs. It's more of a pain control. I think theoretically, nitro has a lot of good things about dilating coronary arteries and reperfusing the heart, getting more blood flow, reduce the ischemia. But there's no evidence that it has anything to do with morbidity and mortality in STEMIs. No evidence whatsoever. So if something can cause you harm, especially if you're not 100% sure that this isn't right-sided, I'd worry more about tanking their blood pressure than giving them nitro to relieve their pain or help. Because there's no evidence showing that it's going to do anything for the morbidity and mortality of that patient. Giving them nitro is not going to save their life, but could cause you to get into a sticky situation whenever you drop somebody's preload in a condition that is preload dependent on blood pressure. Right? Okay. So I don't think that we have enough time to go through the next one. We won't go through it all the way. We'll talk about it in general about what the key take-home points are. What are the key take-home points on this?
Don't assume
Don't assume that
Don't assume somebody's a drug seeker because you're going to get burned. It may happen once or twice in your career, but we're in a profession where you can never be wrong. So being wrong once or twice is not good. Now, are you going to be right every single time? No. But drug seekers have problems too. Drug seekers get sick, and drug seekers get issues. Now, am I just feeding every person that comes in with pain full of Dilaudid? No. Is there other things? Is Dilaudid going to tell me whether or not they have a life-threatening illness? No. Can I do something else to see if they are having a life-threatening illness without feeding the beast? Sure. You can do everything that we just did, minus the Dilaudid. When it all comes back normal, you can do whatever you want for them. You know, or you can just give them what they want and send them home, you know. That's probably what I do about 90% of the time, because I'm just tired of arguing with people. I've argued with them all the time for 5 years, and there's no point. It's just, all it does is make you more of a jaded person than them. Yeah, it doesn't do anything, they don't care. Yeah, I would say the biggest take-home point from this, out of all the Mona and stuff like that, is that they have chest pain, get an EKG. It is a super easy, super fast, and great test to make diagnostic interpretations off. If they have chest pain, get an EKG. This guy, get an EKG, EKG comes back stone cold normal, then you just move them on out the door, right?
So this was pulling of the upper chest. Just make sure that pain is different in different people.
Right.
And when we did cardiology, we were referring to this as a posterior lead look. Remember that term of moving? So right-sided, posterior, whatever you want to call it. The other thing, remember, is reciprocal changes. So you would expect possible ST elevation on the opposite side of your depression. Make sure you're seeing the opposite side and looking. If you're seeing depression somewhere, look at the opposite reciprocal area. Remember those?
Yeah, I went to a course, the SEMPA course this year, and I went to an EKG class, and the guy that talked about it talked about how you try to pick one diagnostic test that you run in the emergency department that can give you the most amount of information on a majority of subjects that can be life-threatening. And it was EKG, like, yeah, point of care glucose, for somebody's hypoglycemic, or electrolytes with the CMP. There are so many things, from tachyarrhythmias to ischemic changes to pulmonary embolisms to electrolyte abnormalities to environmental, cold, hot, different things that you can see on an EKG. And it is so fast and so easy to look at, and non-invasive too. Okay, so this case here, we're just going to kind of run over here in the next 5 minutes. I know you guys are getting close. So, a female presented to IMSA with AMS. She's tunted and groans to questions, found down by friends. They provide no details. You don't know anything. Her vital signs are somewhat stable, except for a slow respiratory rate of 8. She's tunted, but her airway's intact. Her GCS is 10. She has no focal deficits apparent. So, the take-home point to this one was in these patients that can't provide any history or tell you anything or answer any questions, you need to have a very wide differential on these people. And so this one was kind of designed to trip you up a little bit depending on what you missed and did not order. The diagnoses could have changed. So it could have been a Tylenol overdose if you guys didn't order a Tylenol level. So this one is designed to trip you up. I mean, I make this one extremely difficult, and I want you to end up killing the patient so we can teach you this. But we can't work through this, so we're just going to have to tell you. These people, drug intoxication, overdoses, you don't know if she just, took, 30 Norcos that has a ton of Tylenol in it in an attempt to kill herself, or what. So Tylenol, aspirin level, urine drug screen are extremely important in these people. Make sure you get an EKG on them. Look for either some QT prolongation or QRS widening, looking for any kind of toxidrome there. This also could have been an epidural hematoma because she fell and hit her head because she was drunk and no one saw. Now she has massive brain bleeding and herniation. So don't forget to CT scan these people, especially when you have no bystanding witnesses and they are altered. You need to make sure that they don't have any bleeding on the brain, because it'd be a bad case. All of a sudden you're just kind of sitting there waiting, all of a sudden they really start to crump and herniate, and you don't really know why. So make sure you got to image their head. And then it also could have been a hypercapnic respiratory acidosis if you didn't get arterial blood gas, because these people can take opioid pain medicine, decrease the respiratory drive enough to where they are still oxygenating. So you see that her oxygen saturation is 94%, but over time they start to build up CO2 because they're not exhaling enough and their rate's not enough. Then all of a sudden they become super hypercapnic and their PCO2s in the 70s and 80s, and that's why they are continually worsening mental status. It has nothing really to do with anything other than their PCO2 is elevated with that. And so these are the type of people that can come in that way, and you give them Narcan, because she had, I think pinpoint pupils, I don't know if that was in there, and a respiratory rate of 8, and nothing happens. Then you kind of think to yourself, oh, well, it's not opioid overdose because I gave him a bunch of rounds of Narcan and nothing happened. Well, you reverse the opioids, that's great, but that did nothing for the hypercapnia that she has, which is now causing her mental status change, right? So need to look at those blood gases on those people. And so this case is just designed to approach a patient with a very wide differential because you don't know what's happening, and there are a lot of deadly diseases that could happen to these people that you need to be aware of. And
How do
so,
you fix hypercapnia?
I went to ACL a couple of weeks ago, and I literally think I lost 20% of my hearing. I'm not kidding. I can't hear anymore. I'm not joking. It's sad.
Don't you want to speed up their respiration?
Sure. You want to give them blow it off? That's how you do it normally.
What did he say? What initially caused
So what would you do?
What
How do you
caused
speed up the
that?
respiratory rate?
What was she doing? Just her low rate
Yeah, tube them.
caused the hypercapnia.
Knock them down, tube them. Can you do BiPAP on these people? Just, okay.
Don't get into that.
Yeah,
It comes later,
that's another
this-
discussion.
Before you get out of this course, you will have
Yeah,
that
you
down.
can't do BiPAP on these people because they're not awake and alert enough to tolerate it. And BiPAP doesn't really do anything about increasing your rate. That's a breath-driven thing. Okay, I'm sorry I took so long. So let me ask you this here. Would you feel it'd be more beneficial to just start with the cases, to do like 20 seconds, 2-3 minutes worth of how to develop differential diagnosis, even though you guys seem to already just kind of shook your head with that, or just go straight into the cases and start working our way through it?
Just do cases.
I like you saying how you do your differential.
Yeah.
It's like the brief and then
Okay.
the cases.
It was very brief.
All right, I'll try to briefen it up. I'll take out the vital sign stuff. I'll take out the physical exam stuff because it always seems that we get over on time. I think it's because I'm
The tier
long-winded,
1,
but
tier
I
2
think
thing
these are
was
good
good.
ones.
Yeah, that was good.
Yes.